So we've talked a bit about these autonomy levels, where we are today and what's going to happen over the next 5 years. Could you elaborate on that a little bit?
I mentioned the autonomy levels that you can distinguish. So as being a second reader, so as an assistant, you could also go to a first reader, where the software does the first read, and then the radiologist remains responsible for the report, but kind of reviews the findings that the AI had. And next level would be a rule-out system. Mm-hmm. So especially in a screening environment, you can imagine that if 90% of the scans are negative, it would be a huge productivity boost if AI would be able to rule out the 90% that have no findings, so that the radiologists can spend their time on only the 10% that actually are worthy of their attention, so to speak.
Is this something that the industry is already looking for?
Definitely. If you're looking at, for example, screening programs across Europe that are being set up right now, is that one of the biggest challenges for these screening programs to be implemented is simply the capacity of the radiologists. So they simply don't have the people to be able to run such a program. Mm-hmm. So in that sense, you could argue that having AI is a requirement to even consider having such a program. So I think it's very important that is why this keeps getting developed and these regulations become clear on how when is it safe to do this and under what conditions.
Why would autonomous levels or autonomy, full autonomy of AI, not work in routine clinical practice?
Well, the question is if you would want that, because I think the question you have there is very different, and also the patient population you have is very different. So for screening, you're trying to answer a very specific question, but in routine practice, I mean, of course, there can be hundreds of different reasons of why a scan is made. And I think it would be, too much to ask, but also not very effective to try and answer all those questions with AI systems. I think humans are extremely good at integrating data from different sources and finding the weird exceptions and rare cases, and whereas AI is very good at, say, the standard work and routine stuff that is very similar from one case to the next. So say detecting things, segmenting things, triaging maybe, classifying things. These are tasks that it would make sense that you have an AI to do that for you, because you can see on a study basis that if you have enough training data and if you develop it well, it will do it on at least the level as a human reader. And of course, it's easy to scale.
Yeah.
So I think there it makes a lot of sense.
But technology by the next 5 years will not be capable of doing generalizable tasks for full CT chest reach, for example.
No, and I honestly wonder if that is also where you want to focus your attention, because I think one thing that would be much more interesting is trying to combine different data sources. So until now we've been talking about radiology images. So there's one image and then you try and infer things on that. But of course, from a patient or from a treatment perspective, there's much more data. There's the patient records, there may be pathology slides, there may be a PET scan, there may be other sources of data. And you can imagine that what software is good at is combining data sources on a pixel level, and to see if there's anything that you can learn from combining that.
So basically that's where you're already touching upon our next slide, the impact of AI on a workflow. Integrating data sets and integrating different silos or different parts of the care pathway.
Yeah, I think this is I think a little further out. But I think there is a promise there, and also integrating multiple data sets across the pathway is one aspect. The other one is when you think about, say, holistic imaging, is that one of the things, for example, that we are working on at Aidence is also to add coronary calcium scoring on the chest CT, because on the same scan that has the lungs, obviously you also can image a heart, and we know that the risk groups overlap a lot between lung cancer and coronary disease. So it makes sense to be able to deliver that. But when you do that, say from a clinical pathway, it's quite different, because one, say, customer of that would be the pulmonologist and the other would be the cardiologist. So how does then having a kind of holistic diagnostic in there influence or change the clinical pathway? Do you want that? When does it make sense and when does it not make sense? So I think there is an opportunity for AI to ask questions on how do we, say, most effectively organize the diagnostic pathway.